Okay, well, welcome everybody to our April 14th Tuesday meeting on Zoom. As we see, we've got a lot of participants that are just joining the meeting now. We're really looking for this to continue to grow, and we're happy to have all of our Rotarians on today. I hope everybody's staying safe. A ton of rain today and tomorrow makes renting cars a lot of fun. So we'll just say that. I hope everyone is enjoying the time at home. We're glad to have Lori on as well with us today. I thought that maybe for the uncomfortable first 10 minutes of every meeting every week, we can have Lori do a skit in the background for us before we get started, because that was a lot of fun. I enjoyed that. Thank you, Lori.
You're welcome. I still don't know where my phone is, so if y'all see it, please let me know where you think it is.
All right, I'll have Mr. President Chad text you during the meeting to locate that. And before we get started, and before I kick it over to Joe to start the song, I just wanted to remind everybody that for announcements today, if there's something that comes up, please include that in the chat under the, if you have an announcement. I didn't get any updates from anybody today. Today we have 0 announcements on the agenda. So of course, send that to me. I'll review and see if it's worthy. Send it to Chad, and then Chad will decide if we're going to throw that on the announcements today. So we'll be happy to do that. And then in addition, before we kick off our song and pledge, if you are a visiting Rotarian, please click the chat button and give us your name and club, and we'll give you an opportunity to introduce yourself during the meeting as well. So with that, Joe, if you could please take it away with our song and pledge.
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you, Joe, for running that. And before we kick it over for our invocation with Lori, I did mention visiting Rotarians and visitors as well. Please hit that chat button as a reminder. All right, Lori, hopefully we can hear you and you're ready to rock and roll. Take it away, sir.
Okay, let's just have a word of prayer together. We are very thankful for the abilities you have given to some to guide us through times of great difficulty. Physical events that have the potential for taking lives, for causing damage, creating high levels of anxiety and pain. And as we move forward in the pandemic experience we have never experienced before, we ask for continued strength and wisdom to negotiate our daily activities. We do pray specifically for those in the medical professions and providers of essentials who cannot be practicing social distance from others. Protect them all, we pray. And we commit ourselves afresh this day to be those who value service above self in the days, weeks, months, and years before us, however long it takes us to rebound from this experience, especially as we hopefully begin to move out of the pandemic in the next weeks. Guide us in the how-to of restructuring our lives, our communities, our nation. I pray in your name. Amen.
Thank you, Lori, and thank you for that indication today. Joe, my mute wouldn't come unmuted, so Chad must have worked some magic back there behind the scenes.
I pray for that.
So let's see. Richard, if you've seen these updates really quick, I'm getting back. Do we have any visiting Rotarians or visitors today? Looks like we have a guest, William Boyles, PhD student. If we'd like an announcement or a introduction, that'd be great.
Hello. Okay. Hi. I've got with me my son, William Boyes. He's a graduate student in physics at Columbia, hiding from the pandemic here at home. So he's a PhD student in physics. Keenly interested in whatever data Mr. Fugate has today, or insight. Thank you.
Okay, well, thank you very much and welcome to the meeting today. Glad you're here. It looks like we have Miss Susan on as well.
I'm not sure if Susan's going to unmute. Susan, if you want to say hello.
You can
If
see her
not,
on your screen.
I'm going to introduce
Richard,
Susan,
you need to unmute her.
my wife.
Okay. Well, if we miss anyone, welcome William and Susan. Glad you're here today. You can add a note, and we'll see if we can squeeze you in. Do we have? If you could hit the chat, if we have any announcements. Currently, right now, we do not have any announcements. So if we don't have any announcements or a chat doesn't come through, we'll go ahead and ask President Chad to take it over.
All right, thanks, Jason. I don't really have any comments either. I'm excited to get to today's program. So Richard, would you introduce today's speaker, please?
Yes, happy to do that. So our speaker today is Craig Fugate. I think probably most of you know that from the messages that we have sent out in advance of this. We're honored to have him today. Mr. Fugate served as the National FEMA Administrator under President Obama from May of 2009 through January of 2017. And previous to that, he served as the Emergency Management Director under two Florida governors, Jeb Bush from 2001 to 2007, and Charlie Crist from 2007 to 2009. During his tenure as Florida Emergency Management Director, Mr. Fugate was widely praised for his management, especially during the devastating effects of the 2004 and 2005 Florida hurricane seasons, where we had literally, this is a long list, Hurricanes Charlie, Francis, Ivan, Jean, Dennis, Katrina, and Wilma. It's a lot of names. While at FEMA, Mr. Fugate led the agency through multiple record-breaking disaster years and oversaw the federal government's response to major events such as the Joplin and Moore tornadoes, Hurricane Sandy, Hurricane Matthew, and the 2016 Louisiana flooding. At FEMA, Mr. Fugate set a compelling mission for the agency and drove a set of priorities which were focused on achieving better outcomes for survivors. While there, Mr. Fugate oversaw the agency responding to more than 500 presidentially declared major disasters and emergencies. FEMA's effectiveness during that time restored faith in the federal government's ability to respond to disasters. And we're very grateful to Mr. Fugate for his willingness to speak to us today. So please join me virtually in welcoming him to this virtual meeting today.
Well, I'm off mute, so first question is, can you hear me? All right. I thought I was going to be coming to you from my laptop where I was going to do a little PowerPoint, but the storm that came through this morning knocked out my cable, so I don't have much internet. So I'm on my phone. And I'll go through I'll go through what I was going to talk about anyway, which was initially when they asked me to do this, it was very topical to talk about the upcoming hurricane season. But then we have COVID-19, and the question was, with COVID-19, the emergency management response, also looking at what we will be doing for the hurricane season. So let's start with COVID-19. Why is a pandemic different from most disasters? And if you think about hurricanes for Florida, a hurricane hits and we're able to pull resources from across the state as well as across the country to respond to that. A lot of people moving in and out of disasters, a lot of volunteers, everybody from utility crews to National Guard deploying in. And that model has always been based upon most disasters are what we call geographically placed. Terrorist attacks, hurricanes, earthquakes, wildfires, they tend to be geographically limited to the area of impact, and the rest of the nation can give up resources and support that response. Pandemics are different, and they're similar to another type of disaster that we fortunately haven't faced, but we're also having to look at, and that is cyber attacks. And that cyber attacks and disease outbreaks are rarely going to be geographically fenced. They're going to go across the networks, whether it's computer networks for cyber or people networks for a disease. And with a pandemic, the planning now has to be all 50 states are being impacted at near the same time frame. And it's difficult to free up resources from one part of the country to the other. We have seen some limited ability, such as California, being able to free up some of their ventilators because they've been more successful at minimizing the amount of patients that are going into their hospitals and send those to New York. But by and large, we're not seeing large deployments of personnel or equipment. We are seeing things like our national pharmaceutical stockpile being deployed and other resources. But those are generally coming from supply chains, not from other states. And so think of it this way. Again, we get hit with big hurricanes in Florida. We can ask the rest of the nation for help. During a pandemic, there's not that much we can ask for. And the federal government has finite resources. So if you think about it, again, it's geographically not, and again, with a pandemic, it's not just going to be the US, it's going to be all other nations. So that when we talk about medical supply chain, a lot of what we need is no longer manufactured here in the US or manufactured in sufficient quantities. So we depend upon a lot of overseas manufacturing of key parts of this response. And probably the biggest piece of this has been protective equipment, both for healthcare workers, but for other frontline workers. Outside of social distancing, the next best thing we can do is to make sure we have enough protective equipment so that people being in environments where they cannot shelter at home, they have to physically go into work, or they're having to interact with the public in general. PPE, or the protective equipment, the masks, the goggles, the gowns, the face shield, all of that becomes a key part of this response. And most medical health supply systems were also based upon a just-in-time delivery system. I like to say that the efficiencies of our systems mean they're not very resilient. So none of our systems were ever based upon large numbers of consumables in a pandemic. And this had factored into a lot of the planning we had done, going all the way back to the Bush administration. President 43 had started a lot of work on pandemic planning. And then as we were planning for H1N1, the last time we had a pandemic, it was something we saw during that planning that protective equipment was going to be a critical need. So move forward to COVID-19. All of the pandemic plans were really based upon early detection overseas. If the pandemic occurred in the United States, if we were at a point of origination, there's a lot of health surveillance systems that are built in. But we had seen that a lot of these, particularly the COVIDs, the coronaviruses, were originating overseas. And so a lot of time and thought had been given into building up overseas monitoring. working with countries where we had seen this before, because for the CDC, or Center for Disease Control, the sooner we know that we have a new virus, particularly one that can be spread human to human, and they can get samples of that virus, the sooner they can begin developing the testing, the protocols, and the screening. That did not happen the way we had planned for. There had been a lot of cuts, reductions in overseas monitoring. Obviously, our attention to China exacerbated that. And by the time there was the first reports of the virus and the CDC was able to get their first samples, by and large, we had lost the ability to isolate this and contain it from our shores. I like to remind people that COVID-19 moved at the speed of air travel. And while everybody was looking to block travel from China, it wasn't taking into account that people had traveled through those regions, through other parts of the world. In fact, many of the East Coast cases were coming from Europe. We saw cruise ships becoming amplifiers of this early on, but the reality was we more likely had COVID-19 earlier than we first knew. This is something that they're doing in a lot of areas, like particularly the West Coast, is trying to go back and look at respiratory illnesses that presented COVID-19 symptoms, but we didn't know we had COVID-19. They would test negative for the flu and other types of viruses, and trying to go back and extract how early did it get here. There's a lot of data that suggests that we probably saw cases maybe as early as December, but definitely in January and February. And what happens when you lose containment, or the ability to rapidly test, take the people that are testing positive and get them into a quarantine situation where they can treat them, and do contact tracing to everybody they've been exposed to and get them to go in isolation, you see what happened in the US. And that meant we had to move to social distancing. Social distancing is not a new idea. It goes back to our fight with the 1918 pandemic when we were dealing with influenza. It is something that came up again as we were planning for H1N1. It is the one thing we know we can do to slow down the spread, is to wholesale populations going into to basically stay at home except for essential workers. And as we saw the numbers going up, the West Coast actually did this earlier. And I think part of the reason they were able to do it earlier is a lot of the big tech firms out there, first thing they started doing was canceling conferences, because we saw how conferences were contributing to the spread. Second thing was they began issuing work from home directives to their staffs. And because the big companies like Apple and Microsoft and Facebook and Twitter and all of those companies moved in that direction, I think it made it much easier for the local health officials and state health officials to then begin ordering community-wide and statewide shelter at home and social distancing. And as it moved into other parts of the country where we did not implement that faster, we saw challenges. And one of the is the catch-22. By the time I know I have COVID-19 cases, it's a little bit too late to begin social distancing. And it's about a 2 to 3 week lag time between the time you do social distancing and you begin to see the curve flatten. So in a lot of parts of the country, the numbers are still going up rapidly, and it will continue to do that for several weeks even after they do social distancing. As we've seen in New York, about 3 weeks after they went to a citywide shelter in place, those numbers are flattening down, but it does not mean it's over. And there's a lot of questions about what's next, how long is this going to last, when do we go back to normal? We did not go back to normal until there is a vaccine. Until we can vaccinate enough people and develop enough herd immunity where this cannot continue to pass from people to people, we're going to go into a new phase as this first wave is coming through, where we're going to have to continue a lot of new social norms. Wearing face masks in public, not handshaking or making contact, maintaining distances. But I do think we're going to start moving towards parts of the economy reopening, but it's going to be key to two things: testing and protective equipment. Until we can make sure we have enough PPE or protective equipment for people that have to interface with the public, the people in the healthcare industry, our first responders from law enforcement and fire, people that work in grocery stores, food distribution, and as you're seeing now in the news, meatpacking houses and production there where they've got COVID-19 and shutting down those areas, you're going to have to very slowly and selectively begin starting back up. And we need to be prepared for the fact that we may have rebounds where we'll have to go back into sheltering in place. And this will not be even across the country. Everything goes back to normal commerce. There's going to be a lot of modifiers. There's going to be a lot of things being done because the key thing about COVID-19 is right now it is only transmitted by humans. It is human to human transmission. It does not require close physical contact. It has airborne properties. And so until we can get enough testing to more rapidly isolate and reduce the amount of spread, as long as people have the virus, we have the potential for it to come back. Well, then on top of all of that good news, it's hurricane season starting in June. And the 2020 hurricane season, the seasonal forecasts are already saying above average, which I didn't need them to tell me. You can look at the temperatures in the Gulf of Mexico. It's extremely warm for this time of year. And a lot of the factors favorable for hurricanes seem to be in play this year. We already saw the last couple of days severe weather across the south with tornadoes. We have flooding. Disasters won't stop for the virus. And so as we start looking for the hurricane season, this is going to be another challenge, and that is we know we're going to have to evacuate people. We know we're going to have to shelter people. And the numbers in Florida can literally be in the millions of people have to evacuate. And with people being a vector, moving people out of areas for safety for hurricanes could also inadvertently spread the virus. Particularly those people that are positive for COVID-19 or are in isolation in their homes. Those folks evacuating, we're going to have to give them a lot of thought about how we evacuate them safely and where they should go. But our messaging really won't change because we have always told people when a hurricane threatens, people in the evacuation zones need to go to the shortest distance to friends and families, hotels and motels, and as a last resort, public shelters. We're currently working with the state of Florida. Some of the things they're thinking about is because we have so few occupancies in hotels and it doesn't look like our tourist season will come back, that maybe the first choice for a lot of folks will be hotels and motels. And because so many people are out of work, will not have money for that, may not even have money for gas, is to think through using programs that FEMA historically used after a storm hits to put people up in hotels and motels for longer term sheltering and maybe be able to do that on the front end so we minimize the amount of shelters. The second thing we're going to have to look at is the need to bring in a lot of volunteers and workers after the disaster. Volunteers are the backbone of a lot of our programs where we feed and take care of folks. But again, moving a lot of volunteers across the country may not be advisable. And again, we need to kind of look at this from how do we do what needs to be done with moving the fewest people possible. We're going to have to move search and rescue teams. We're going to have to move the National Guard and other specialized capabilities. But we may also have an opportunity to utilize the people that live in the communities that are being impacted. And that is all of the food service workers, the restaurant workers, the hospitality industry currently are out of work. And there's nothing that FEMA says we cannot hire people to prepare meals and feed the people that have evacuated. People that have lost power may not have anywhere to prepare meals. And it may be a way to change how we've talked about disasters is look more at the folks that are in the community as the emergency workforce and put them back to work. We're seeing this with some organizations in some cities that are already contracting with restaurants and utilizing that capability to feed people during COVID-19. So it'll be another option to look at that. And then the last thing about hurricane responses, we're probably, if we're still dealing with after COVID-19, we're probably not going to be able to do the full recovery like we would normally do. I think we may have to do our rescues and life-saving, mass care, taking care of people, emergency repairs, but we may not be able to do everything. We may have to delay picking up debris. We may have to delay starting permanent work until we are at the point where we can test enough people and start bringing back the workforce. But we're not going to get out of hurricane season. Disasters won't stop for the virus. But a lot of people ask me, when do you think we can get back to going in more normal activities? And I keep coming back to, until we have adequate testing, that's a very hard question to answer. And I think everybody's trying to set a hard date that May 1st or the end of May or June. It comes back to how much testing do we have? How active is the virus in our communities? And do we have the PPE and hospital capacities? Or are they already at extreme lows like we see in New York? Relaxing social distancing there would just make it much worse. So there's a lot of moving pieces here. And as several people have said, this will be dictated by the virus, not by policymakers. And our concern is if we let up too soon, we get a rebound and this comes back full force and we lose control of the virus. But we also have the other part of this is businesses are dying. And the longer we are in this shutdown, the more unlikely that many parts of the economy will survive. And so this is a race. Can we test fast enough to begin selectively bringing the economy back on board without losing control? And do we have enough capability to do testing at a scale that has never been attempted before? If you just think about all the healthcare workers, all the people that support the healthcare workers, all the people on the front lines of interface with the public every day in the essential industries that are still open, all the people in the background that work in the warehouses, distribution, trucking, and others, being able to test those populations and make sure that they're safe and giving them PPE would exceed our current capabilities before we start anything else. So it comes back to testing and PPE. And if you're wondering why I'm not saying ventilators, ventilators are key. But again, there's more and more data coming out that the ventilators are only useful in some cases. More important is the PPE and protecting people, particularly the frontline healthcare workers, and the ability to test and isolate patients. Those are the really big macro challenges we face as a nation. Until we get there, it's going to be very risky to start reopening things. There are some countries that are a little ahead of us that are going to try that. I think we're going to see what's working and not working. But again, I would urge caution. So like the rest of you, I work from home. We're only going out for essential things. And a lot of that we're trying to get delivered as much as we can. We're fortunate we can do that. We know a lot of folks have lost their jobs. They're not working. Their businesses are crashing. And I think this is one of our challenges that unlike most disasters, this one is going to produce the economic impacts that most of our federal programs aren't designed for. And that's why it was so critical for the first round of the stimulus package and why I think Congress is going to have to continue stimulus packages. So summation, pandemics are everywhere all the time, unlike a disaster where we get hit and it starts to get better. COVID-19 is transmitted human to human. As long as people are carrying the virus, it has the potential to spread and flare up on us. And until we have a vaccine, there's going to be a lot of activities that are not going to be possible or will have to be heavily modified. So we know we're going to go through the 2020 hurricane season without a vaccine. The question will be in 2021, will there be enough vaccine to start getting back to a normal response? But in any case, here in Gainesville, fortunately, very few of us live in evacuation zones. Our biggest challenges will be power going out and trees coming down, as we've experienced before. Part of the stuff about people getting ready for COVID-19, stocking up, is pretty much what we would do for hurricanes. But I think we have to be prepared for a slower recovery. It may take longer to get power back up. It may be longer before we get debris picked up. But the life-saving and the critical functions will still occur. It'll just be a little bit different. So with that, I'm ready for any questions, and thanks for having me today.
All right, fellow Rotarians, if you have any questions, the easiest way to get that started is just go right down in the middle of your screen, hit the chat button, and Joe will read those questions off. So good news is we have just over 90, I think 90 people on today. So, we are getting more and more Rotarians on for our Zoom meetings, so that's great. And Craig, that was an excellent update, so I'm sure we have some questions for you. I'll mute myself and please go to the chat button. Thank you.
Hey, Craig, I have our first question, which came in about 15 minutes ago from Bob Mounts. The question is, what is your understanding of the president's legal authority in a public health emergency vis-a-vis the authority of the governors?
Well, I'm afraid the Supreme Court, unless they throw the Constitution out, will find that the governors have the primacy in a lot of these state police actions and authorities at the local and state level. This was one of our planning assumptions when we looked at H1N1. The federal government does have some role there. The CDC does have some role there, mainly for interstate and borders. But within the states, the governors have the primary authorities under their state constitutions. So again, I think that our planning assumptions were that the federal government was really about rules and tools and money, but the governors would be the implementation of that under their authorities. And it's a kind of an area that we touched on during Katrina. If you remember, President Bush 43 had said after Katrina, there may be disasters that require the president to take over. And his brother, Governor Bush, said that'd be the worst decision his brother ever made. So, hopefully, as I always try to figure out is the federal, state, and local level distinctions are probably not as critical to the public. We need to work as one team. But when you see these unilateral decisions that are being talked about, it does give pause, because it's going to be a big debate over our federalist form of government versus a national government. And the constitutional scholars and people that actually set through civics and understand our federal government and federal system of government are probably very concerned that these statements are being made. The caveat I'd like to add all this is, while it's just really seductive to say we should just have one person in charge of all this, I go back to the founding fathers. They weren't interested in an efficient government because they saw that as being the preview of kings and dictators. What they did was build a very resilient form of government. And if you think about how our states operated, and you think about the federal government cannot do everything to the degree that governors can. And if you did it that way, it becomes a single point of failure. We've had uneven response among governors. But think about how this response would look like if governors had not used their authority, stepped up, and done a good job of managing the effects in their states. And I think, the debate will go both ways. And many times people look for quick, easy answers. We did not have a government that's built for quick, easy answers. And ultimately, this may end up in the Supreme Court to decide who has primacy here. But I think the understanding that most people have is it would be a very questionable decision to make unilateral decisions that are generally considered the authorities under the constitutions the states have.
Thanks. Thank you, Craig. The next question is from Dana Miller. Can you discuss the possibility of a mandatory COVID-19 vaccine?
Well, we went through this with swine flu under President Ford. And the whole issue was we were facing another virus that was very similar to the influenza pandemic in 1918. They rushed to a production of a vaccine. It was the first time that we saw where the federal government actually had to provide indemnity to the vaccine manufacturers because of the concerns that it was being rushed through production, the testing and everything else. But the decision with H1N1 was not to do mandatory vaccinations, but to make it available to everybody and strongly encourage them to take the vaccine. And if you remember, President Obama was one of the first people to get his shot. It wasn't that he was front of the line. It was to reassure people that the President of the United States was getting a vaccine, and if they weren't sure it was relatively safe, that would have never happened. So we haven't seen the mandatory vaccination requirements, but we do know that for people who won't be vaccinated or people who become ill with this, there still may be other activities, particularly quarantining or requiring people to stay in isolation. So those are tools that we are using right now with COVID-19. But we've never really gotten to the point where it was mandatory that you had to have a flu vaccine. It was just strongly encouraged. I don't know if that changes with COVID-19. I don't think so, but I think the challenge is going to be we have to have a vaccine first to have this debate, and we have to have enough of it to vaccinate enough people that we actually could have the option of people turning it down versus it will have to be rationed in the beginning. And the bigger problem we're going to have is who gets the vaccine first.
All right, thank you, Craig. Next question is from Toby Monaco. Should testing include asymptomatic people when they are going back to work?
Yeah, that's the big debate. Right now, we don't have enough testing to really cover people that are having symptoms. But the idea would be you need to make sure the workplace is safe, and being able to augment that, because right now what they're doing is they're doing screenings, they're doing temperature checks, they're issuing PPE. But if you can test larger segments of the population, particularly those folks that are interacting with the public, because what you want to do is get a baseline. You know, people that either are carrying enough, and this is still a question mark. We don't know for certain that if you've been exposed to COVID-19 and you have antibodies to COVID-19, how much immunity is that conferring to you for how long? But by at least testing people and knowing they are not currently infected and allowing them to come back in the workplace, that would allow us to bring things back online. Everything from office settings, but probably more important right now is if you're seeing the stories about food processing facilities where COVID-19 got in there and having to shut the whole plant down, they're having to go clean everything, and it's going to cause the potential for some disruptions in supply chains. Those would be relatively short term, but it is going to cause some challenges. So if I was trying to reopen my meatpacking plant, I just don't want to rely upon temperature checks or health histories, because what we found out was a lot of people are carrying the COVID-19 virus. They're not necessarily even presenting symptoms, or they're having very mild symptoms. So the ability to do testing and say, all right, anybody that's going to work in this meatpacking plant has to be tested every 2 weeks to make sure that we're not getting COVID-19 in that workforce. But that's why I think this is going to be much different than just testing people who are sick or have been exposed to somebody as sick. It is this widespread testing to allow us to bring things back on safely and come back up to speed. But that means testing on a scale that has never been done before in order to do that.
Thank you, Craig. The next question is from Don Bugus. The World Health Organization historically estimated the annual mortality burden of influenza to be 250 to 500,000 deaths globally. However, a 2017 study indicated a substantially higher mortality burden, 290,000 to 650,000 influenza-associated deaths from respiratory causes alone. Yet no country shuts down. What are your thoughts on that?
Well, the death rate on influenza is much lower than COVID-19. We've only been dealing with COVID-19 for 3 months to speak of that we've seen it, really getting going here. Its attack rate and death rate is higher than influenza. And a lot of the influenza deaths are due to secondary bacterial infection, which that's why we encourage all of us geezers to make sure that we've had our flu shots and our pneumonia vaccines so that we don't get bacterial pneumonia. COVID-19 is different. So a lot of the early questions about, well, it won't be as bad as the flu's a lot worse, we go through the flu, we don't shut down. Generally, unless we are dealing with a novel virus and the influenza, there's a lot of inherent immunities from previous flu seasons. We also have vaccines. They have none of that for COVID-19. And what you saw in New York City was never like a flu season. You'd have to go all the way back to the Spanish or the 1918 pandemic to even see numbers approaching that. So the caution has been, when you talk to the health experts, comparing influenza, seasonal influenza, even some of the more virulent strains against COVID-19 is kind of a mixed bag, because much of what we know about influenza, we don't know about COVID-19 yet. And look at the numbers in New York City. When was the last time you saw that many flu-related deaths in that short a time? And that should give us an indication that when we do not have social distancing, we have potential for very large numbers of people getting sick, and out of that, a much higher rate of people dying from COVID-19 than we have traditionally seen with most of the influenzas in the last 20 years.
How is the nation supplied for oxygen, tanks, and other forms of oxygen?
No indicators there. In fact, the real shortfalls are again back to the protective equipment, the testing, and to a certain degree ventilators, although I think ventilators are becoming less of the issue. There's a lot of work now that suggests that ventilators may not be the best first line treatment, and there is not apparently, and nothing has really come up about oxygen or oxygen delivery systems like cannulas, masks, and other devices. Most of the shortfalls and focus has really been on protective equipment, and those are your masks, the goggles, the gowns, the gloves, the sanitizer, and then ventilators, and then testing.
How does FEMA coordinate between federal and state governments?
Well, traditionally, and even in COVID-19, it's very similar. When the president declares a major disaster declaration, FEMA works with the governor's team to coordinate state requests. And the difference is, unlike a hurricane, where we may be dealing with a half dozen states at most, you're dealing with all of the states, all of the territories, and all 50 states have disaster declarations. So this was something we had looked at FEMA, and part of the challenge is staffing all that. And well before we had tools like video conferencing, Zoom, and others, and we did a lot of video conferencing at FEMA, we would have to deploy people to each state EOC. They have done that to some degree, but because FEMA also has 10 regional offices across the country, so here in Florida, our regional office is in Atlanta, it's Region 4. A lot of this can be done virtually. Because in most of this, it's about processing requests for assistance or processing payments, reimbursements under the grant program for disaster response. And so the federal government, particularly FEMA, can either do this in person in some states where they've had more activity or it was earlier. Other states where they're having relatively light exposure right now, they can do it virtually. But that was our plan as far back as 2009. It was staffing the governors and the territories simultaneously to coordinate that. And again, FEMA's headquarters in Washington, but you have the 10 regional offices that are scattered across the country that work with their states on a daily basis. And so the coordination will go from those states to that region office, and then from that region office up to headquarters.
Craig, do you know when China first shared the science of the virus to let scientists around the world analyze the virus to begin working on a vaccine?
No, I mean, most of everything I've seen is probably what you've read. It was in January. Although the intelligence community started seeing some reports about respiratory virus, and it was different. And the Chinese, well, let's put it this way, the Chinese were a lot more forthcoming on this than they were on SARS. SARS was even more of a challenge finding out what was going on. So it appears that there were some signals that the intelligence community was seeing earlier than January. But about January is when most of this started to come out, and that China was reporting to the World Health Organization that there was a new virus, although there were still sketchy details. And I don't know when the CDC got their first actual samples of the virus to begin developing their testing kits.
How do you know which models of infections or recoveries to believe when the scientific community does not seem to agree? Is it possible to know from the data when the pandemic is quote unquote over before the vaccine comes out? So many are trying to predict. What are your thoughts on that?
Well, I think that most of the models are, again, projections of spread based upon the virus itself, how easy it is to transmit, and then the population and protective measures. And again, it's interesting trying to describe this. We look at most flu seasons, even really bad flu seasons, and we'll see that peak, and then the numbers start coming down. And once they get to a certain point, it seems like the flu just goes in the background. It's just not being spread around a lot. And we do see those seasonal variations. So I think people have been thinking that as the virus peaks with COVID-19 and starts flattening down or coming down the other side, that it will follow a similar pattern, and that particularly as we get warmer weather, more humid weather, and it's not as easily spread, it will essentially burn itself out. The caution, however, is unlike flu, only 1 or 2 people with this virus are still able to spread it. And since we are the reservoir and the host, we don't know if there's a seasonal variation. There were some National Academy of Science papers that came out on what they call quick studies. They find the virus does better in a certain temperature and humidity range, but they're also finding it still able to spread, still able to be on surfaces, and that it's not necessarily conclusive that we'll see that seasonal. And the way I've described this to my peers is, think of a forest fire. We have the fire contained. That's at peak. It's flattening out, but it's not out. And if we let down our guard and conditions change, that fire can come roaring out. So until we're able to extinguish the virus through vaccines, as long as that virus is still in the population, it's not over. And so if we can get the number of people down to a more manageable level where we can test and isolate and quarantine them, treat them, and keep them until they're no longer spreading the virus, we'll be able to move away from a lot of the social distancing we're doing now. But until we have vaccines, the virus is still out there. And we don't see, and there's not enough history yet to say that it will follow a similar pattern to influenza, where it will literally go through that peak, come down, and essentially go into the background, and you'll see very few cases. We don't know if that's possible with COVID-19. And so a lot of the concerns are, we'll see this come through in waves. If we are not careful, we could have it explode back out. And this is why it's so critical, as we're watching other countries trying to reduce their social distancing, trying to get their economies back. What are the challenges? And as we move into warmer temperatures, is that slowing down the spread? But I like to remind everybody, it's been in the 90s in South Florida. So we'll see, maybe even in Florida, is it the social distancing or temperatures? Probably too early to say. But our planning assumption is it will be here throughout the year. It may flare up and go down based upon our ability to isolate, test, and manage it that way. But I don't think we're out of the woods until we have the vaccine.
Craig, would you be able to compare this to the polio crisis?
Yeah, fortunately with polio, it wasn't as easily spread. Otherwise, polio had been much worse. But, you know, I was born after the polio crisis. When I was born, we did have the vaccine. I remember as a kid going to the public health department and getting everything from the sugar cube with the vaccine on it to my smallpox shot in my shoulder. But in the summers before we had a vaccine, we saw very much social distancing. Pools would close across the country. Parents kept their kids home from school. And because it was so hard to determine who had the virus until you got sick or how it was being spread, it struck fear in the communities. It was something that it seemed to have no rhyme or reason to who got it and who didn't get it. A little bit different with COVID-19. We know that if we can protect ourselves against the airborne particles, if we maintain social distancing, we can do a lot of things to protect ourselves. But polio was scary because it was just so random, it seemed, on how people got affected. Like people in a household, one person would get it and nobody else would get it, and you really couldn't figure out, well, how did they get it? We know more now, but until we had a vaccine, polio was a terror for communities every summer. And it was very much something that they saw seasonally. But it was, you know, people would talk about in the early spring, summer months of hearing the sirens as ambulances were being called to homes where somebody woke up unable to move or paralyzed, showing the symptoms of polio.
do you have any suggestions or ideas if more should be done for first responders, frontline personnel, et cetera, to protect them and their families, as well as allowing them to continue the work they're doing?
Yeah, we need to have them all in N95s or other appropriate masks, gloves, and testing, particularly for our first line responders. And I think the priority is going to have to be the people that are in the healthcare industry, that are in the hospitals on the front line treating people. And then it needs to be our first responders, National Guard, and other folks that are out there. And the problem is, without testing, we can't tell who's gotten infected unless they get symptoms. We're already having to put firefighters and paramedics and law enforcement officers into isolation. They are getting sick. There have been reported deaths across the country. So yes, absolutely. But the challenge is right now, there's not enough PPE for everybody. So the focus has got to be on the people treating infected patients. They need the highest level of protection. Those N95 masks and everything else they have to wear. But ideally, we get to the point where we can now start moving that level of protection out to the frontline workers to protect them, combined with testing to make sure we're detecting early, particularly for the fire service, where we may have 3 to 5 people working at a station. One person sick means we could lose the entire shift. So everything from the paramedics that are going out there with the patients to the fire crews, to law enforcement. And then ultimately, we need to move that to the food service workers, the delivery folks, the people in the grocery stores. I mean, this is one of the things that's pretty telling is when you have, you're out now actually counting the number of people who work in grocery stores that have gotten sick and those that have died as considered essential workers. Yet many of them didn't have availability of any protective gear, and we still aren't really in a place to test them all to make sure we're catching any exposure early.
All right, do we have any more questions? All right, well, Craig, thank you for speaking to us today. Very informative. What an excellent program. We appreciate your time and you being here. And we are going to inoculate 100 children from the polio virus in your name as a thank you to you.
Thank you. That's an honor. I appreciate that.
Yes, sir. All right. If there are no further questions, our meeting is adjourned.